Good morning to all of you. So today we are going to study unconsciousness part 2. Part 1 we have already studied earlier, in which we have studied the definition of consciousness and unconsciousness, the causes of unconsciousness, sign and symptoms, etiology, and we have already studied the diagnostic test and detail. So today we are going to study unconsciousness part 2, which includes the medical management, the surgical management, the nursing management. In nursing management, we are going to divide into two parts, that is emergent care or emergency care, and second is the routine care. We are also going to study about prognosis, and thus we will end the topic. Okay. Now we will study the medical management. Okay. So in general, the medical management is, the goal of medical management is to preserve the brain function and prevent the further damage. Okay. So we have already studied the causes. So different causes will cause unconscious to the patient. So the main goal here is, whatever brain function is there, that has to be preserved, and we don't want further brain damage. So for what do we do? What we do is, we put the patient on ventilator. Okay. So because the patient we know that we have a respiratory center in the brain stem. Okay. So whenever you have patient with head injury or any issues which are causing unconsciousness, the respiratory center is bound to be affected. Okay. So the patient has to be put on ventilator. So we put the patient on ventilator support, because the lungs are not functioning well. So naturally you have to give oxygen therapy. Because the brain is affected, the blood pressure also varies. It may come down, or if the patient is hypertensive, you may even have hypertension. This all will depend on what is the cause of unconsciousness. So the blood pressure also need to be managed. And next is, we need to manage the seizures, because the brain is affected, the patient may be having seizures. Okay. To manage this seizures, we give anti-epileptic drugs, and this anti-epileptic drugs are fosphenytoin. Okay. And then if the patient is very irritable, we need to give sedatives. But sedatives, when you give, we have to be very cautious, because many of the sedatives, they depress the respiratory center. Okay. So we need to have a balance between to what extent we are sedating the patient. Okay. Next is paralytic agent, because if the patient is very irritable, then we need to give paralytic agents. So paralytic agents can be ketamine. Okay. So this is first part of the medical management. Okay. Now is we are continuing with the medical management. So here what we are going to first is treating increased intracranial pressure. Okay. So you imagine that the patient is a case of head injury. Okay. So what you have is, whenever all of you must have seen patients with head injury, and whenever you have patients with head injury, you may have collection of blood in the brain. Second is, you may have leakage of CSF. Okay. So blood also requires space, CSF also requires space. Okay. So the final result is, the intracranial pressure is increased. Okay. The intracranial pressure is increased. So how do we know that the intracranial pressure is increased? We see for certain signs and symptoms. What are those signs and symptoms? Signs of increased cranial pressure in adults is headache, nausea, vomiting, hypertension, decreased mental abilities, confusion, unreactive pupils, shallow breathing, seizures, loss of consciousness, coma. Okay. I will repeat it once again. Signs of increased intracranial pressure is headache, nausea, vomiting, hypertension, decreased mental abilities, confusion, unreactive pupils, shallow breathing, seizures, loss of consciousness, and coma. Okay. So these are the signs of increased intracranial pressure. So we need to treat increased intracranial pressure. So what do we do? What we do is, we give mannitol. Okay. So we give mannitol, and mannitol, what does it do? Mannitol draws water out of the brain by osmotic gradient and decreases the blood viscosity. this decreases intracranial pressure and increases the cerebral blood flow. Okay. So, see, this is the cerebrum. Okay. So, if you have, see here you have a collection of blood. So, if you have collection of blood here, this compresses the cerebrum. So, this will depend on where the collection of blood is. Okay. So, suppose if you have blood collection in all these areas, so the result is you have pressure from all these areas. So, cerebrum is because it is a very soft organ. So, whatever pushes it, here we are talking of a blood clot. So, this pushes it. So, when this is pushed, the amount of the cerebral blood flow is reduced. Okay. So, once the cerebral blood flow is reduced, so the result is all the functions which are controlled by the cerebrum is also bound to be reduced. So, what does mannitol do is, mannitol does two things. First is it draws of water from the brain. Now, you have the brain, you have lot of collection of water. So, it draws off water, and second is this is done by a osmotic gradient, and this decreases the blood viscosity. If what is viscous, if the blood is more viscous, then the blood will not flow easily. So, it does two things, it draws off water from the brain, second is makes the blood less viscous. So, once you have a blood which is less viscous, it can flow easily. Okay. So, the result is these changes, they decrease the intracranial pressure, and at the same time they increase the cerebral blood flow. Okay. So, that is the importance of giving mannitol. Second is corticosteroids. Corticosteroids have many functions. Here corticosteroids also decreases the intracranial pressure. Okay. So, that is why we need to give corticosteroids. Now, what is the normal intracranial pressure? Normal intracranial pressure is 5 to 15 milligram mm of Hg. Okay. 5 to 15 mm of Hg. Any values which are equal to 20 or more mm of Hg is increased intracranial pressure. Okay. Normal is 5 to 15 mm Hg or mm of mercury, or if it is 20 mm of Hg or more, this will lead to then this will be labeled as intracranial pressure. Okay. Now, how do we measure intracranial pressure? We can create a burr hole, and we can check the intracranial pressure. Okay. So, this is how we, so because to check it is difficult, so what we need to do is we observe the signs and symptoms, and then we can have see if you have a patient with head injury, take a CT scan, you can see this clot. Suppose this is the type of picture if you see. So, the result is we know that intracranial pressure is increased. Okay. We also have to refer the clinical signs and symptoms. Okay. So, this is why we give mannitol and corticosteroids. Second is management of temperature regulation. See, hypothalamus is our temperature regulating center. So, if you have issues related to brain, the temperature regulation, the patient may be having fever. Okay. So, for that we need to give tepid sponging, we need to have ice packs, we need to have antipyretics, and we give non-steroidal anti-inflammatory drugs. Okay. So, these non-steroidal anti-inflammatory drugs, they block the COX enzyme and reduce the production of prostaglandins. Okay. So, once you give non-steroidal anti-inflammatory drug, they the inflammation, pain and temperature, these three are reduced. Okay. So, prostaglandins, what they do is they promote inflammation, pain and temperature, and prostaglandins are produced in our body in response to illness or injury. I think the concept is clear now. Now, you have a patient maybe with illness or maybe with injury. So, the final result is prostaglandins are secreted. So, when prostaglandin is secreted, what do? They cause inflammation, they cause pain and temperature. So, what does non-steroidal anti-inflammatory drugs do? So, what they do is they block the COX enzyme and reduce the production of prostaglandins. Okay. So, once the prostaglandins are reduced, the inflammation, pain and temperature are reduced. Okay. I think the concept is clear now. Okay. So, whenever you have injury or whenever you have any injury or any illness, prostaglandins are produced in our body. So when prostaglandins are produced in the body, they cause inflammation, pain and fever. Okay. So we give non-steroidal anti-inflammatory drugs. So what they do is they block the COX enzyme, and COX enzymes are what they which produce prostaglandins. So in this way, the inflammation, pain and temperature are reduced. Okay. Next is management of elimination. For that we need to give laxatives and we have to give a high fiber diet. Okay. Now how to manage nutrition? It is total parenteral nutrition, or we also opt for right tube feeding. Okay. So depending on the condition of the cause, we decide all these things. Okay. Next is deep vein thrombosis prophylaxis. DVT is deep vein thrombosis prophylaxis. We know. So now you have a patient who is unconscious. So he will be lying as it is, because many of the time unconsciousness may be coupled with hemiparesis or maybe paraplegia or a quadriplegia, depending on what is the cause of unconsciousness. So what we have, if you have such type of patient where the patient is lying limp, so there are chances that the patient can have deep vein thrombosis. So if you have patients with deep vein thrombosis, the biggest issue is deep vein thrombosis. If the clot becomes this is dislodged from the place, this can cause pulmonary embolism, which can be very troublesome and even it can be very fatal for the patient. Okay. So what we need to do is, we don't want deep vein thrombosis to occur. So what do we do here? So first is we have mechanical therapy. So mechanical therapy can be a decompression device. We also have stockings available. So these stockings will be applied on the legs of the patient, so that this will have a mechanical compression, and this deep vein thrombosis will not be there. And next is drug therapy is there. So drug therapy, we can give a low dose of heparin, which are anticoagulant, or we can give orally warfarin. Next is third is we go for passive exercise. Active the patient will not be able to do. So passive range of motion exercises, the physiotherapist can come and they can give the passive exercises. So these are all involved in deep vein thrombosis. Okay. Now this is surgical management. Okay. Surgical management is, can you see this, craniotomy. Okay. So this is a craniotomy procedure where this bone flap, okay, this is the bone flap. Okay. This bone flap is removed. Okay. We cannot have it like this. This is removed, and this bone flap is kept in the abdomen. Okay. Nowadays it is kept in the abdomen. Why? Because now what we require is this flap has to be removed, so that whatever compression is there, that has to be released. Okay. So that is why this area's bone flap is removed, and this is cut off, and this is kept in the patient's abdomen. Okay. So this bone flap is kept in the own patient's abdominal pocket. This is safe, easy, cheap, sterile, histocompatible and better cosmetic results. Okay. So this is very good, and I was going to different research study. So many patients have been treated like this. It is also practiced in India also. So bone flap is kept in the abdomen. So when the patient becomes all right, next is we can take this flap, bone flap of the skull from the patient's abdomen. We can resuture it. Okay, can you see this? This is again resutured. Here it is removed. Here it is removed. Okay, once it is removed, whatever suction, if some collection of clot or if some collection of CSF is there, that can be suctioned, that can be removed. All these things are done, and then after maybe some months, depending on the condition of the patient, this flap, which is kept in the patient's own abdomen. So this is sterile because it is in the patient's body. It is safe, it is cheap, it is easy, it is histocompatible, and the cosmetic results are good. Okay. So this is what we do. Next is cranioplasty and burr hole. Burr hole is we create a hole and then we take out whatever clot or collection of CSF acid. These are the surgical interventions. Okay. Now, we are coming to nursing management. Now, what are the goals of nursing management? To maintain adequate cerebral function. Okay. So, next is we want that the patient should be normothermic, that is the patient should have a normal temperature, should be free from pain, discomfort and infection, and should attain maximal cognitive, motor and sensory function. Okay. So, what is cerebral perfusion? Cerebral perfusion is blood flow to the brain is called as cerebral perfusion. Okay. So, the blood pressure and intracranial pressure, the blood pressure and intracranial pressure affects the cerebral perfusion. They affect the cerebral perfusion. Okay. So, if the BP is less or if intracranial pressure is more, both of this decreases the cerebral perfusion. Okay. I think you have what is cerebral perfusion? The blood flow to the brain is cerebral perfusion. We have just 2-3 slides before we have studied what is intracranial pressure. Okay. So, if the intracranial pressure is more, we have studied that it presses over the cerebrum and the blood supply of the cerebrum comes down. So, if the intracranial pressure is more, the cerebral blood flow is decreased. Next is if BP is less, if the patient is hypotensive, okay, BP is less, then what we have is the cerebral perfusion is decreased. Okay. So, decreased BP and increased intracranial pressure, they decrease the cerebral perfusion. Okay. So, these are the goals. Now, is emergency care of nursing management of unconscious patient emergency care. Okay. First is airway breathing circulation management is to be done. Okay. So, the main issue here is we have to maintain a patent airway. Okay. So, what we have is we use a oral artificial airway to maintain the patency, and if the patient has to be put on ventilator, so we have two options, either tracheostomy will be there and then we put the endotracheal tube, or what we have is endotracheal intubation and then we can connect it to the ventilator. Okay. So, these two things can be done, and we ensure that the airway obstruction is not there. Okay. So, this diagrams denotes the endotracheal tube intubation. Okay. Next is we have arterial blood gas analysis. Okay. Arterial blood gas, I think all of you must have seen how it is taken. So, we need to take a arterial blood, okay, not a venous blood, it is arterial blood. So, we have to take the arterial blood in a heparinized syringe, keep in a tray with the ice cubes. Then the tip of the needle has to be cogged, because the air outside air also contains oxygen. So, this will cause changes in results, and we have to send to the lab immediately, so that we can get the correct results. Okay. So, in ABG we need to find out whether the patient is in acidosis or whether the patient is in alkalosis. Okay. So, we have three things, one is pH, the second is PaCO2 and HCO3 minus. Okay. Depending on that results, we find out whether the patient is in acidosis or alkalosis, and depending on that we manage the patient. Okay. So, this was about maintaining a patent airway and the ABG results. Now, this oronasopharyngeal suction equipment may be necessary to aspirate secretions. Okay. All of you must have taken care of unconscious patient. So, what we want is not what we want is you must have heard the gurgling sound, because so for example, if I am conscious, so if I have some secretions in the oral cavity, I will swallow those secretions. Okay. But the unconscious patient will not be able to do so. So, what happens is there is a pooling of secretion. So, that is why we need to do the suction. Okay. So, oronasopharyngeal suction equipment will be necessary to aspirate the secretions, and if facial palsy or hemiparesis is there, the affected side is kept the uppermost. So this is how you manage. If some dentures are there, we remove the dentures, and nasal and oral care has to be given 4 hourly, and it has to be free. See, upper airway has to be free from accumulated secretion, okay, debris. All of you must have seen a brown coating is there because the patient is usually a mouth breather. The mouth is kept open. The oral cavity has to be taken care repeatedly. The nose also will be full of debris, so that has to be cleaned every 4 hourly. Okay, so that is why we need to have a nasal and oral care. Okay, and this upper airway has to be free of accumulated secretion debris. Okay, next is we need to monitor neurological signs. And how do we monitor? We take a Glasgow-Coma scale, and depending on the Glasgow-Coma scale, we monitor the neurological signs and symptoms. Okay. Now is ineffective cerebral tissue perfusion. So this is the nursing diagnosis. So what do? We assess the Glasgow-Coma scale, SpO2 level. SpO2 level, we have a pulse oximeter. So that will give us by using that we can monitor the oxygen level of the patient, which is non-invasive, and we take the arterial blood gas. Okay. So first is GCS. So we can have a neurological assessment to find out the oxygen saturation. We have SpO2 by using a pulse oximeter, which is a non-invasive technique. And third is ABG. By that we can find out whether the patient is in acidosis or alkalosis. Okay. Next is we need to have a vital signs, and many of the patients, they will be having fever because the hypothalamus is affected and the temperature is usually not regulated properly. Okay. Next is head elevation of 30 degrees. Neutral position is maintained to facilitate venous drainage. Okay. Studies have been found out, and now it is clear that if we, for every 10 degree increase of head elevation, intracranial pressure decreases by 1 mm of Hg, and central perfusion pressure decreases by 2 to 3 mm of Hg. Okay. I will repeat it once again. For every 10 degree of head elevation, intracranial pressure decreases by 1 mm of Hg, and central perfusion pressure decreases by 2 to 3 mm of Hg. Okay. So the usual criteria is we increase the head elevation to 30 degrees. Okay. So this is how, this helps to facilitate the venous drainage also. Okay. Next is reduce agitation. We need to sedate the patient. As I have told you earlier, we have to do this very cautiously because many of the sedatives, they depress the respiratory center. So once you give sedatives, we have to watch for changes in respiration. Next is reduce cerebral edema. I have already talked about corticosteroids. Osmotic is mannitol, and third is loop diuretics. Okay. So loop diuretics are given after osmotic, that is after mannitol we give loop diuretics, that is Lasix. Okay. So once we give Lasix, the advantage is it helps to prolong the osmotic effect. And what is the osmotic effect? We have already studied that this draws out water from the brain, and second is this makes the blood less viscous. So this effect is prolonged if you give loop diuretics. Okay. So this is what we do to manage cerebral edema, and it is seen that this cerebral edema or intracranial pressure, they peak within 72 hours after trauma, and gradually it comes down. Then when we talk to the patient, talk softly and limit touch and stimulation. Many times if we touch the patients will overreact, will become more irritable. Okay. So we have to limit touch and stimulation, and we have to talk softly. One thing to always remember is many times we may be feeling that the patient is unable to hear what we are saying, but studies have proved that even though the patient may not be able to talk, may not be responding to deep painful stimuli, but still the patient may be able to hear. So, do not talk anything which can cause problems to the patient. Okay? So, we have to talk softly and limit touch and stimulation. Administer laxatives if the patient is not passing stool, and if the patient is vomiting, then we need to give antiemetics. Manage the temperature with antipyretics and cooling, and if seizures are there, we give Dilantin, that is phenytoin, and we give mannitol 25 to 50 gram IV bolus if ICP is more than 20. Okay. Next is risk for increased ICP. I have already talked about head elevation. Next is I will be talking about suctioning. Okay. Suctioning is, we have to be very careful regarding suctioning. Suctioning can be endotracheal suctioning, so it has been seen that if you do suctioning, then there is sudden increase in intracranial pressure. Okay, there is sudden increase in intracranial pressure. Okay, suctioning causes a sudden increase in intracranial pressure. So, what we need to do is we have to pre-oxygenate before suctioning, and second is when we pass the catheter, we have to not exceed 10 seconds. Each episode of suctioning should not exceed more than 10 seconds. We have to be very careful. I would like to add something here. So, if you are doing endotracheal suctioning, what we need to do is we have to pinch the endotracheal catheter, introduce to the level where we need to introduce, and then you release. Many times what people do is they don't pinch it, and the whole of the path wherever this catheter is going, this is going to injure the mucosa. I have seen patients, when I was a clinical, I have seen patients because of the bad technique of doing suction. Two people had to undergo tracheostomy. Why people? Because people were not knowing how to do suctioning properly. Okay, so by doing suction, we should not create more injury, mucous injury to the patient. So what we need to do is, see, the tip of the catheter can injure the mucosa, which is very delicate. Okay, so when we do the suctioning, two things to remember. First is pre-oxygenate the patient. Next is we pinch the catheter, introduce to the level where we need to suction, release it, and once you release, it will suck. Okay, then you pinch and then you remove. Okay, so and each episode should not exceed more than 10 seconds. And why are we doing so? Because it has been seen that suctioning causes a sudden increase in intracranial pressure. Okay. Next is insertion of oral airway. I have already told you. Second is fluid intake is restricted and glucose is avoided to control cerebral edema. Okay. So cerebral edema occurs when does cerebral edema occurs? When the extracellular fluid enters into the intracellular compartment. Okay. And when this occurs in brain cell, so this causes cerebral edema. Okay. And if hyperglycemia is corrected too rapidly, then cerebral edema takes place. Okay. So that is why we need to this fluid intake is restricted and glucose is avoided to control cerebral edema, and intravenous infusion cannot be considered as a nutritional support. So if this is not possible, then we introduce a rhinestone and then we give the fish to the patient. Okay. Next is the nursing management of unconscious patient, that is routine care. Okay. So intake output chart has to be meticulously maintained. That you all must have seen in the clinical area. Whatever, even if you give 10 ml of fluid, so that has to be recorded. Intake and output has to be recorded, and then you assess for symptoms of fluid overload or fluid deficit. Okay. So fluid overload, how do we know? The basic problem is edema. Okay. So there will be weight gain. Next is there will be edema in the face, the hands and the legs. Then there will be swelling in the abdomen. There will be cramping, hypertension. The patient will be having shortness of breath. So these are the symptoms of fluid overload. Fluid deficit, the throat will be dry. The patient will be having weight loss. Okay, we can test the skin turgidity, all these things. Okay, so we need to see whether the patient is having fluid overload or fluid deficit. Okay, so we need to assess and document symptoms. which may indicate either fluid overload or fluid deficit. Next is if it is fluid overload, we need to give diuretics, and so this will correct the fluid overload and reduce the edema. And overhydration and IV fluids with glucose are avoided in comatose patient because this will lead to cerebral edema. Okay, so we don't want cerebral edema to take place, so we give the glucose is avoided and overhydration is avoided. Okay. Next is skin integrity. So because the patient is unable to take care of the skin of his own, so this unconscious patient is dependent for everything including skin integrity. Okay. So here the nurse should provide intervention for all self-care including bathing, hair care, skin care and nail care. Okay. Frequent back care has to be given to prevent beds. So then comfort devices has to be used. Now we have air beds, we have water beds, and if you have taken care of patients in water beds and air beds, you will find there is a shifting every 15 to 20 minutes. There is always a shift of positions. Okay, so this bed automatically it is constructed in such a way that air or whatever it is, this will shift from one place to the other. Okay, especially in air bed, this is this mechanism is there. Okay, then position should be changed every 2 to 3 hourly. Special mattresses air beds can be used. Adequate nutritional hydration status should be maintained. Nails should be kept trimmed, otherwise the patient can injure himself. Then cornea should be kept moist by instilling methyl cellulose 0.5 to 1%. Okay, because you must have seen unconscious patient, they will not be able to close the eyes. It may be either open or it may be half closed. So there are chances that the eye may become dry. So what we need to do is we have to instill methyl cellulose 0.5 to 1%. Okay, so this can be there, and we can check for corneal reflex. And how do we do it? We take a wisp of cotton and touch the side of the cornea, touch the side of the eye in the cornea. So if the patient is blinking, then this indicates that the corneal reflex is there. So this is how we check it. Now protective eye shields can be applied, or eyelids can be closed with adhesive tapes if the corneal reflex is absent. If the corneal reflex is present, is well and good, but if it is not there, then we need to protect with eye shields, and this will prevent corneal abrasion and irritation. And once we should remember that if the cornea is affected, then this can even lead to blindness later on. Okay, so we need, this is a major nursing care we need to focus. Okay, then we need to inspect the oral airway, then keep the lips coated with water soluble lubricant. I was talking about earlier that unconscious patient will be keeping the mouth open. Okay, and see, for if the person is a conscious patient, when we talk, when we take, when we eat anything, there is a continuous flow of saliva, and this is how our lips are moist and also our oral cavity is moist. But that is not the case with unconscious patient. The unconscious patient is not talking also. The unconscious patient is a mouth breather. So that is why his mouth will be always open. So this leads to more dryness. So we need to have a water soluble lubricant to prevent encrustation, drying and cracking, and we also need to inspect for paralyzed cheek. Okay, so depending on that we need to take care. Frequent oral hygiene every 4 hourly. Nasal passages, if it is occluded, they have to be cleaned with a cotton tip applicator. Can you see this bed sore? Okay, so this has to be prevented by frequent changing. Okay, can you see this huge bed sore which has occurred because of poor nursing care? Then proper positioning, lateral position on a pillow to maintain the head in neutral position, so that can be given. Upper arm should be positioned in an elbow so that the shoulder alignment is maintained. Upper leg also has to be supported in a pillow to maintain alignment of the hip. 2 to 4 hourly the position needs to be changed, and taking care to prevent injury to the soft tissues and nerves, edema and disruption to the blood supply. So this all needs to be maintained. Okay, then maintain correct positioning, enables the secretion to drain from the client's mouth. The tongue does not obstruct the airway, and postural deformities are prevented. Now, self-care deficit, attending the hygiene needs of the patient. Patient should never become ritualistic despite the patient's perceived lack of awareness, and dignity should not be compromised. So, when we take care of our unconscious patient, we have to give dignity to the patient. Okay, we have to involve the family in the self-care needs. The fingernails and toenails also needs to be assessed, and if the patient is a diabetic patient, so this patient needs more attention, because we know that the wound healing is delayed, and when we are taking care of unconscious patient, it is better to have two nurses, because turning may block the airway. So two nurses together should take care of a patient especially when you are giving the basic care. Okay. Then assessment of skin, that has to be done, and hair care should not be neglected. And this is a repeated slide. In eye care, we have to see for signs of irritation, corneal drying, abrasions. Okay, gentle cleaning with gauze and 0.9% sodium chloride should be sufficient to prevent infection. We can even go for eye irrigation. We have a undying, we can use a normal saline, and we can even have eye irrigation. Okay, we can have a kidney tray kept in the side of the eye, and then we can do a eye irrigation using an undyed. Okay. Artificial tears also can be applied as drops to moisten the eyes, and corneal damage, so tapes can be used to close the eyes. Okay. Nutritional needs, TPN, total parenteral nutrition. Okay. Enteral feeding, this can be given through nasogastric, nasojejunal, or it can be a PEG tube. What is PEG? Percutaneous endoscopic gastrostomy tube. Percutaneous endoscopic gastrostomy tube. So, what we have is, it is a flexible feeding tube which is placed through the abdominal wall, and it is given directly to the abdomen, to the stomach. Okay. So, this is a PEG tube. Okay. So, what we have is, so this is a Ryle's tube, but if you have a PEG tube, you will have a hole here in the abdomen, and it is directly, you have a pipe directly into the stomach of the patient, and this is how you give it. Okay. And this is we have a stopper attached to it. So, when we want to feed the patient, we attach the syringe, and then the fluid goes by gravity. Okay. So, this is how similar to what we do for Ryle's tube feeding. Okay. And IV fluids are administered for comatose patient. Then there is risk for injury, because the patient may be irritable. Okay. So, side rails has to be kept whenever the patient is not received direct care. Seizure precautions must be taken. Adequate support to the limbs and head must be there when you are moving or turning the unconscious patient. Protect from external source of it. So, all these things we have to be very clear. Over sedation has to be avoided, because then it is difficult to assess the level of consciousness, and as I have already told you, this affects the respiration also. Then we need to assess the need for restraints. Okay. So, if the patient is very irritable, then we need to have restraint, and whenever we apply restraints, we have to be very careful. It should not be too tight, and then it has to be a padded restraint, and then after applying restraint, we need to check the areas for C for color, C for pulsation after applying the restraints. Okay. Next is impaired bowel and bladder functions, assess for constipation and bladder distension, that we need to assess. Auscultate for bowel sound by using a stethoscope. Stool softeners or laxatives may be given. Bladder catheterization may be done if the need is there. Then catheter care must be provided under aseptic techniques, that whenever you have a patient with unconsciousness, we have to catheterize the patient. Okay. Monitor the intake output, or also color of the patient, and once the patient is conscious, we have to initiate the bladder training. And how do we give bladder training? Once the patient is conscious, ask the patient, once the catheter is removed, ask the patient to initiate urination. This may take time after the catheter is removed, and once the urine starts flowing, then ask the patient to stop in between, and again start, stop in between, and again start. So, this is how you train your bladder. There is risk for contractures. Maintain extremities in functional position by providing proper support, that is, we keep the upper arm, we keep the upper leg on the pillow. so that the shoulder as well as legs are in a proper position. And then we have a passive range of passive exercises, skin cares every 4 hours, and to prevent foot drop, we can have a sandbags applied to the end of the foot, so that foot drop does not occur. Okay. Then sensory stimulation. Brain needs sensory input, and widely believe that hearing is the last sense to go, that I have already told you. Talk and explain to the patient what is going on. And studies have proved that once the patient wakes up means when the patient becomes conscious, he will accurately recall the events and process that happens when they were unconscious. Okay. Then the nurses must show respect. They encourage the family to contribute to the care of loved ones, and afford the privacy both for the patient as well as for the family, because they deserve it. Okay. And how do we encourage the stimulation? By massage, by combing and washing hair, by playing music, radio, maybe a CD or maybe a TV, reading out a book, bringing in perfumed flowers, and update them with the family news. Okay. So family members also can involve in all these things, and when they are interacting with an unconscious patient. Okay. Then impaired family processes there, so include the family members in patient's care. Communicate frequently with the family members, because see, having an unconscious patient in the family is very, very stressful to the patient, and they will be having many doubts about the current situation, whether it is deteriorating, whether there are signs of improvement. So we as a nursing personnel can play a very important role to communicate frequently with the family members. The family members should be allowed to stay with the patient as and when possible, and external support system, for example counselors or maybe religious clergy person. So this gives a lot of support to the patient. The patient might not be knowing, but it is for the family members, it is a great support when a religious clergy is allowed to go inside the ICU and pray for the patient, or if they are not allowed inside, at least they can interact with the family members and pray for them. And many hospitals, they have prayer centers where, depending on the religion they follow, they can pray for the patient, and the stress can be reduced. Okay. Clarification: questions should be encouraged from the family members. Now, what is the prognosis? The prognosis of the patient who is unconscious is very variable. Why? Because the cause is variable. It is highly dependent on the etiology, to what extent the brain is injured, and individual patient factors. Okay. So traumatic brain injury is the most studied etiology of the coma, likely due to its high prevalence and highly variable outcomes. So traumatic brain injury, the estimated mortality is 40 to 50%. Okay. So patients with non-traumatic etiology do not recover quickly, they may even have a worse prognosis as compared to traumatic brain injury. It is from 25 to 87%. Okay. So patients who have a non-traumatic loss of consciousness lasting more than 6 hours had 1 month mortality rate of 76%. Okay. So that is the issue related to prognosis, depending on which is highly dependent on what is the cause, and second is it is highly dependent on what are the individual factors and to what extent the brain is injured. Okay. Now, what are the complications of unconsciousness? There will be permanent initial brain damage, secondary brain injury from anoxia, coma, aspiration pneumonia, bladder bowel dysfunction, and scale ulcers. Okay. So that was all about unconsciousness, where we have dealt in detail today about the nursing care and also the medical management, the surgical management and nursing management. We have divided into the emergency care and the routine care. I hope all of you have understood. So please listen to the topic, and if you have any doubts, you can clarify. Thank you for your patient listening.